Let's go and get started. It's my, let's go and get started. So it's my pleasure to introduce Dr. Luci Leykum. I think many of you know Dr. Leykum. Dr. Leykum's been a key leader in the School of Medicine. She's a professor in the Department of Medicine and chief of the divisions of both general and hospital medicine. She's a clinician investigator in the institution. She's done research on complexity science and its application to clinical systems, and that's what she's going to talk about today. She's been a good friend and partner to the Department of Surgery, and it is an honor and pleasure to introduce Dr. Leykum.
Thank you, Alan. Thank you for coming so early on a Monday to hear about complexity. Should I turn off the room lights?
Yeah,
okay. Think y'all can hear me okay? All right. So why are we talking about complexity science? Well, how many of you feel like you work in an optimally functioning clinical system? Yes, okay, one person kind of jokingly raised his hand. How many of you have worked on projects to try and improve the system? Okay, several of you. And how many of you feel like those projects went as expected and you got the results that you wanted? Ronnie gives us a kind of. Okay, so that's why we're talking about complexity, because we need to better understand the nature of the systems that we're working in if we want to have any hope of trying to improve them. So here are my objectives for you for today. I'm going to talk about what wicked problems are and hopefully convince you that that's what we have in healthcare. Plus, it tied in so nicely with the beginning of October and the Halloween theme. We're going to talk about characteristics of complex systems and apply those to healthcare. And hopefully, you'll be able to take at least a little bit of this, and it'll intrigue you, and you'll be able to use it in the future to try and improve the systems in which we work. So to tell you a little bit more about myself, I spent 15 years here. This is Columbia University Medical Center. And when I was there, I felt like I saw the most amazing things. People's lives were truly saved all the time. And then I saw, on the other hand, like a totally dysfunctional system where we couldn't even reliably get labs drawn in the middle of the night. And I asked myself, how is it that the same system can produce such widely different outcomes in terms of total excellence and just total, awfulness? So that's sort of how I started coming to this. And certainly everyone is familiar with the current issues in healthcare. So not to focus too much on this, I know it's small, but basically this was a study of harm in hospitals across North Carolina with chart audits over a 10-year period. The main thing to notice here is that these lines are flat. All right, mortality as a result of ischemic heart disease. Here is the United States. So we are higher than much of the rest of the developed world, right? And we haven't gotten that much better. We've gotten better, but look, we have other countries that are down here and we're out here. And you guys have heard many of those health statistics about how the US lags other developed nations. Now within the US, we have a ton of variability, which is an issue, and here we are in Texas, certainly one of the lowest performing states across a variety of health outcomes. We've got an issue with obesity, and here is the really key question: why aren't we improving? And certainly when you think about what's happening in healthcare policy and reimbursement changes, policymakers are asking that question: why aren't we getting any better? Why don't we see proof that our systems that we're paying a lot for are delivering the outcomes that we want? So when we think about the problems that we're facing in healthcare, they're really difficult problems, right? They're hard to even put a boundary around the problems, right? So I've worked for a long time with anesthesia on a project to try and improve preoperative assessments. And that's not an easily bounded problem. because it's influenced by what's happening in primary care offices, what's happening in the surgeon's offices, how scheduling occurs at the hospitals, the fact that the schedules change dramatically in the 72 hours prior to surgery. Right? So all of those things make it very difficult to address what should be a relatively simple issue. So wicked problems are difficult because the information is often contradictory. Right? Thinking back to Columbia, there were great outcomes and there were bad outcomes in the same system. When you start to think that you're solving a problem, you realize that you just uncover new problems. So this is a picture of melting glaciers, and climate change is kind of the prototypical wicked problem, right? It's hard to bound, it's hard to really work on, and I think healthcare is very similar in that regard. So how do we approach these problems? Well, they're hard, right? So Patrick and I were talking right before, and he was like, I don't like thinking about the complexity of the system. Really, I don't either, because it can be very discouraging. But we have to try. So we often end up doing this, where we're kind of going, okay, I'm going to start here and see where I get, which is a reasonable thing to do, but may not be the most effective. So we're going to talk about complexity from the vantage point of trying to use it to think about systems differently and hopefully be able to make sort of more informed decisions about how we try and improve the system. So I'm a general internist, I'm a hospitalist, and for me, when I think about the healthcare system, I start to think about, all right, what's the context in which I work? So here's patient and provider, and here we are in the hospital, right? So there's a lot of different people there. They're all interacting, but not all of them are interacting with each other, right? So sometimes people have information that others don't have. And let's take that out a little further when our patient leaves the hospital, right? So here was the hospital part of the system. There's some connections with the outpatient part of the system, the patient's primary care physician. That person has connections across the system, going this way. They might have connections with different healthcare systems altogether. But you can see that this is very interconnected, right? How do you even draw a boundary around parts of this? Well, we've got a piece here, we've got a piece here, we maybe have some pieces here, but they're porous. So when we think about complexity science, these are hallmarks of complex systems. You can't easily break them down into component pieces because they're interconnected and they're nested. So think about your hospital unit, right? You have people coming and going to different parts of the hospital. You have providers moving in and out, and you have patients moving in and out, right? So all of those pieces of the system are connected. When you start to work on one, you will invariably influence others, and they're going to push back, right? They're going to push back against what you're trying to do in a way that may or may not help you as you try and work on improving the systems. So the fact that they're interconnected and nested and hard to break down is one defining characteristic of a complex system. I keep trying to use this and it's not working. Okay. The other thing is self-organization. People on the ground are going to get the work done in the way that makes the most sense to them, right? I mean, you all work in a very busy clinical environment, and there are things that you do to make your day easier for yourself. Do the people above you know exactly what those things are? Maybe, maybe not, but probably not all of them. And that information decrement goes up as you go up in different levels of the system. Right, so it's very hard to look from outside of a system or to look from the top of the system down and say, do things this way. Because people have organized in certain ways for a reason, and those are stable patterns that are hard to disrupt. Right, so the flocking birds is the prototype for this. Right, there's no bird leader. They all have rules of behavior that are based on how they interact with each other. And based on that, they move forward. And it's the same in clinical systems. People develop these rules and these ways of interacting with each other that you can't say, oh, this person caused that. It's really caused by the interactions among each other. And then we have what I'm going to call differences in scale. All right, so here's our zombie army. And when you look at it from a very far away vantage point, they all look the same, right? It's just a bunch of zombies. I'm trying to tie in with the Halloween theme here. All right, when you start getting closer, you start to see individual differences. right? You start to be able to see characteristics of individual people. And then when you get even closer still, this might be a patient on the trauma service at UH with his brain coming out. So you really start to get into those defining characteristics. Now, we have to have a system that takes care of patients across differences in scale. So we have to take care of that individual trauma patient in University Hospital, but we also have to take care of populations of patients that may have needs that are not that different from each other. So we are asking the system in which we deliver care to be able to do both. And the way that we approach doing those types of activities may be very different because they are inherently different types of activities. And the final defining characteristic that I want to mention is non-linearities. So I'm sure all of you have experienced times where you've tried to make a little change to the system and something surprisingly large happens, usually in a bad way. Or you make what you think is going to be a big effort to improve something. You're going to try to redesign a way of doing things, and it just doesn't have the impact that you thought it was going to be. And those are the non-linearities. The inputs and the outputs are not necessarily proportional, and they're not necessarily predictable, right? So that's an issue for us. We work in inherently unpredictable systems. We cannot say with certainty when we try and do things that they will happen as we plan. Oops. So let's put that in the context of healthcare systems. So when we talk about things like self-organization and interdependencies, this is how I think they play out in healthcare. All right? We have people that are working together. We're working with patients, with their families. We're working with each other. And that's a relational act, right? We're interacting with each other. Then we've got these processes of care. So we decide, this is what we're going to do about VTE prophylaxis. This is our approach. This is how we're going to do this for every patient. This is how order sets are going to work. These are clinical pathways we were going to develop. Those are all the processes through which we deliver care. And we spend a lot of time here in healthcare. When you hear about lean, quality improvement, process improvement, that's where that's all sort of hitting. And when we think about affordances, that's just what's in the system, right? These are the resources at your disposal. Do you have an MRI? Do you have an electronic health record? Do you have specialists who are going to help you in the middle of the night? All of those things influence how you deliver care because you do or you don't have them. Okay, the physical layout of a hospital floor is something that influences how you deliver care. Getting back to scale, when we think about large-scale things, we think about things that we're applying across the population. So think about vaccinations, standard things for chronic disease management. Right, we want all patients with diabetes to have an A1C checked every 3 months, to have their urine screened for microalbumin every year, giving you medicine examples. But those are things that we want to do for every patient with diabetes, with very few exceptions, right? So when we think about those things that we need to deliver to everyone, there's not much individualization. There's not much sort of medical decision-making or clinical reasoning about that. We start to think about, all right, well, a key factor there is how do we reach people? So it leads us to think, well, maybe the doctor's office is not the place to do that, right? If we want to get people, I would argue, for these large-scale things, we need to be out where they live. Then when we think about these fine-scale things, so for this patient with diabetes, this is how I want to do things differently. This is what I think is important for this patient. That's fine-scale behavior. That really requires an active conversation with the patient. It requires you to think about what's going on with your medical decision-making. And I would argue those are the things that really we need to be the most involved in. And we need to tailor those things to that patient. So that's where you really need people in your office, in the hospital room, in their homes, right? So that's how I think that scale issue, if we think about some of the things we need to do in healthcare in that way, it helps us think about, okay, well, what's the best way to deliver those services? And finally, the non-linearities. Remember, I said there's uncertainty in the healthcare system, and it's at multiple levels, right? There's clinical uncertainty. We can never predict the course of a patient with 100% certainty. So I may know of the patients I admit to the hospital, here's the 10 that are at the highest risk for falls. But I can't say this patient's going to fall tomorrow. Similarly, there are limits to what we know, right? There's just stuff we don't know yet. We don't know what the optimal treatment or diagnostic plan is for every scenario we encounter. And finally, we have this uncertainty in the system. So we have to deal with this uncertainty as providers. So when we think about how complexity science changes the way we think about clinical systems, to me, I would say it really reframes what we look at. So rather thinking of just processes of care and how I'm going to improve, this pathway, we have to think about these interdependencies between parts of the system and how people are self-organized and why they self-organized in that way. Because if we don't understand that, we won't be able to effectively influence it. And then uncertainty becomes a really key aspect of what we need to deal with. All right, so we've talked about those characteristics a little bit in the context of healthcare, but we're going to go even a little deeper. And I think complexity science can help us better understand the problems that we are dealing with, but then also better design solutions, because we're getting a greater sense of what is the nature of what we're dealing with here. So this is a framework that we use a lot, and I think a lot about this uncertainty issue, because to me, that's just so fundamental. If we can't predict what we're doing, then we have to figure out a way to still move forward, right? So when we think about the healthcare system, there's different things that we're doing and different things that influence it. Our patient populations will influence it, their health characteristics. Where we're delivering the care, right? Are we in the hospital, the emergency department? Are we in a minute clinic in CVS? All of those things will influence how the patient gets their care. And then what is the task that we're trying to do? So is it a large-scale task? Are we trying to vaccinate everybody? Are we trying to make sure everybody gets their VTE prophylaxis? Or are we trying to figure out, okay, I have this complex patient. What's the best sort of set of trade-offs trying to manage these multiple comorbidities for this patient? So all of those things are going to affect the level of uncertainty. So what do you do when you don't know what to do? You might look something up, but there's a likelihood that you're going to talk to somebody, right? You're going to ask your senior, you're going to ask your attending. For us, we often turn to the person sitting next to us and say, all right, I've got this really complex patient I'm not sure what to do about. What do you think? So we're talking to each other. We go to the patient. This is a social activity. So when we think about the processes and relationships and resources, for me, I focus a lot here because I feel like that's an area where we've tended not to focus, but again, is really important in terms of how on a daily basis we're trying to navigate the system and take care of patients. And there's actually like a very rich literature from surgery on team relationships, which I find just totally fascinating. So hopefully you guys are familiar with at least some of it. But here's an example. So this is medical team training. This was done in the VA, across many VAs. And I actually don't know if ours was a participant. But basically, they assigned surgical teams to one of two scenarios. One was they just kept doing what they were doing. And in the other ones, the teams had to do a briefing before each case to talk about the case and what they might expect in it. And afterwards, they had to do a debriefing where they talked about how the case actually went, what maybe didn't go as optimally as they would have liked, and what they might do differently next time. And they had a reduction in surgical mortality of 18% versus the sort of usual practice, which was a reduction of 7%. Right, so this is pretty powerful. You're getting these teams to talk to each other. There's another example from the cardiothoracic surgery literature on psychological safety, and it's called Speaking Up in the Operating Room. So this investigator, we'll talk a little bit about her later, looked at cardiothoracic surgery teams that were trying to implement a new minimally invasive technology. She watched them in the operating room. And the thing that was most predictive of how quickly that those new techniques were taken up and how well patients did quickly was whether the nursing staff felt comfortable speaking up in the operating room. Right? So when you have that psychological safety, people are willing to talk to each other. They're willing to say something when something doesn't look right to them. And that's really important in terms of team function. So now you see a lot in sort of healthcare policy about teams. And okay, we need to focus on teams, and that's going to help us, you know, as we improve the healthcare systems. And I do think that's true. There's a lot of different terminology that's used. People talk about relationships, talk about psychological safety, they talk about resilience. I like this one because, oh, and this is a woman that did that psychological safety study, Amy Edmondson. She uses the word teaming as a verb to recognize the fact that it's not just a situation where, all right, here's 5 people, everybody's got their roles and they're doing their jobs, but instead to reflect the fact that this is sort of an active conversation and dialogue among these people who are taking care of the patient. And all of them have something to contribute that may or may not be grounded in their role. So to talk a little bit about effective teams, and again, just to give you a sense of some of the language that's used here, we're talking about things like diversity, people with different viewpoints on the patient, how people communicate, how people are mindful. Are you open to new ideas? Are you keeping an open mind about the things that can go wrong in patient care? Heedfulness is an understanding of how your actions or your behaviors influence the rest of the team. So, you know, if I leave early today, what does that mean for everybody else? Or if my intern has clinic today, what does that mean in terms of how the rest of the team is going to sort of react and respond to that to make sure all the work gets done, right? This is a constant negotiation because people are always coming and going. So there's a lot about high reliability now in healthcare. And the idea there is that we want to have systems that have reliably high performance. And when you look at that literature, and that's really, I think, a buzzword now, but when you look at the literature, they have a lot about teams. And again, you see some similarities here. So this idea of mindfulness and openness to what's happening with the patient, what's happening on the team. I think that deference to expertise notion is very important, kind of ties into respect and diversity. So the person who is best able to help in a given clinical situation may not be who's highest in the hierarchy, right? So I see this all the time, like on my medicine teams, we've got 20 patients. I may know more than anybody else on the team about how we treat pneumonia, but probably no one on the team knows the patient better than the medical student who's working with them, right? So we all have different types of knowledge, different types of expertise that we bring to taking care of the patient, and we need to recognize that that may be different, and it may come into play in different ways depending on what's going on clinically. So why do we care about teams? You know, why do we care about relationships? Well, when you have people effectively working together, a few things happen. First, they create this common platform of shared knowledge off of which they're working. Have you all heard this term failure to rescue? It's also from the surgical literature. Yes. Okay, I love this work because there was one really, I think, wonderfully done study that looked at surgical mortality across hospitals. And the idea was that patients, or hospitals where patients were more likely to die, had more complications, and that's why patients did poorly. Well, when they looked, complication rates were actually similar across hospitals regardless of overall mortality. What was different was that in the low mortality hospitals, the teams recognized that the complication was occurring earlier and more effectively intervened. So if people have a shared understanding of what they think is happening with this patient, they can more quickly identify when something is not fitting in with that shared understanding, when something doesn't look right, when something's deviating from that trajectory, and say something, right? So you can see how this psychological safety aspect fits in, right? I have to feel comfortable speaking up when something maybe isn't wrong after all, but I'm worried about this patient. So that shared knowledge is important. And so this is a Hoberman sphere. You guys may have seen these. They're often used as children's toys. But the idea is when you have this effective team, the sphere is open, right? There's this big body of shared knowledge. But then if you have a lower functioning team or something happens to the team, that sphere of knowledge collapses, right? They don't have that same level of shared knowledge, and they're not as effective as a team. And I also want to talk about networks. Again, in terms of, okay, why are relationships important in clinical care? So I love this example about the Medici family. This analysis was saying, you know, they weren't the most successful family in Renaissance Italy because they were willing to kill everyone and poison their enemies. It was actually just because of physically where they were in Florence. It just happened that Florence was actually at the middle of trade networks that connected them to all these other families in Italy. And that was actually the reason that they ended up being so powerful. And there have been examples of this looking in healthcare to say, okay, for quality improvement projects, let's look at where the team lead was in their social network. And there have been studies that have found an association between how a project leader is positioned within their clinical system and the likelihood of success of those projects. So even for us, the social networks are important. You know, for us, there are 60 of us in hospital medicine. I've been here a while, so I know who more of the faculty are. And so if I know Ronnie, I'm more likely to give him a call and say, okay, I'm not sure about this patient. I'm not sure about this recommendation. Let's figure it out. And I might take a little longer to call someone I don't know. But those types of things matter in terms of patient care. And the last thing I want to talk about with regard to the relationships is something called sensemaking. So this is a term from the organizational literature, but it basically talks about how people come to a shared understanding of what's happening and act based on that understanding, right? So it ties into that shared knowledge. It ties into, I think, into the failure to rescue idea, because people have to come to a shared understanding of what's happening and act based on it, right? So we have to think, this patient's not doing well, we need to act. Or this patient's doing okay, we're not going to change what we're doing. So how does this play out in routine care? Well, we're making sense of things when we try and come up with a diagnosis, when we try and determine the treatment plan, recognizing complications, all of these things. But I would argue that we're doing it not only when we're taking care of individual patients, but when we're taking care of groups of patients. Because we have to decide what we're going to do first, right? And it's how we make sense of what's happening with this group of people that influences how we act. So let's talk about rounding. How many of you round in the same way every day? Okay, a few people. How many of you, well, okay, you don't round in the same way every day. How do you decide what you're going to do first? Okay. What else? Okay, great. All right, so we did a study of inpatient, now these are medicine teams, not surgical teams, but at VA and university. And we weren't intending to look at how they rounded, but because we were following them around, we had that information. And, you know, on medicine teams, there's not an unlimited, but there's several different ways you could round, right? So you could start at the top floor and work your way down. You can start at a particular nursing unit and sort of go out from there. You can start with one intern's patient, then go to the other intern's patients. You can run the board in the team room and then decide who you're going to see. Or you can say, okay, so-and-so is sick today, let's go see them first. This sounds trivial almost. I mean, we make these decisions every day. This is just what we do. But, so here's the teams that we observed. And we observed 9 teams, but it was really 11 because for 2 teams, the attending changed halfway through, which ended up having a huge influence on the team's practices. So we used to have this thing in medicine, the residents run the team. The residents don't run the team. The attending runs the team. The attending can try and do things to give control to the resident, but in the absence of doing those things, the learners really take their cues from what the attending's doing. So here's the number of rounding patterns that we saw. So for example, this team always rounded in the same way every day. Literally for 30 days, they did the same thing every day. So did this team. This team used a bunch of different rounding patterns. Now, this yes or no was whether we saw evidence that they actually discussed how they were going to round. And this was, did that discussion include anything about how their patients were doing? So this may look a little scary, right? So only on less than half the teams was there an explicit discussion of how they were going to round. And on even fewer of those teams did that discussion include what was going on with the patients. More often it was something logistical. Who's in clinic today? Who's got discharges? You know, those types of things were influencing how they rounded. This was just sort of the rounding time for these teams. So can you imagine 2.5 hours? That's painful. It's even more painful when you're observing it and not participating. All right. So, all right. So let's, and I just wanted to, you know, go a little more in depth on this example just to illustrate the types of stuff we're talking about. So, and some of the complexities of using observational data. But basically what we did was we stratified teams based on the number of rounding orders that they used. So, you know, was it one or two? Was it 3 or 4? Or was it all 5? And then we looked at the length of stay, the unnecessary length of stay, and the complication rates for those teams. Okay? So you can see that teams that varied how they rounded tended to have lower unnecessary length of stay, lower complication rates. If they were purposeful in how they rounded, all of those were better. And if they rounded for patient-driven reasons, again, all of those are better. Now, I'm not saying that rounding this way itself led to better outcomes, but I think it reflected something about these teams and how they made sense of what was happening, that were effective in doing that had impacts and was reflected in the outcomes of their patients. When we think about making sense of individual patients, here are the types of things that are in the literature. And we've applied this as well and found that they're significantly associated with those same outcomes. But, so this gets back to, I think, really this shared understanding, right? Is the team having a discussion, an explicit discussion of what are we dealing with here? What do we think this patient has? What's our working diagnosis? Based on that, what specifically do we need to do? Is that unambiguous to the team in terms of today, here's what the plan is? Why are we doing that plan? What can go wrong with this patient? What kinds of things that do we need to look out for? So the situation and task, teams talk about that a lot, at least, you know, in our medicine teams. And that's really our assessment and plan, right? But going those next steps and talking about the why, making sure everyone understands the why we're doing this and what can go wrong, not all teams do that. And whether or not they do that is also associated with the outcomes of their patients. So this team function is very important. Now, we do a lot in academic medicine to disrupt teams, right? We have learners coming on and off all the time. We tend to work in larger organizations where we might have patients on multiple floors. So when you consider the team, including everyone who's taking care of the patient, you probably don't have a stable team all the time or over time. So this is a study not from healthcare, but I think illustrated the point well. So this is a group of people who come together on a team over time. These are at consulting firms. And they have to work on tasks, and here's their project completion rate. This is the number of projects that they do over time. So this is a stable case. The team members work together over time. They get to know each other, their performance improves, and it starts to plateau. When you disrupt the task, you have a decrement in performance, right? You change the task that you're asking them to do. They've got to adjust to that. They've got to learn. And if you keep the team constant, they will learn and they'll get back on their trajectory. But if you disrupt the team, and you constantly disrupt the team, So this team works together like the others to this point, and then the team members start to rotate. Right? They never are able to get back to that level of performance because they're never forming that stable team. And I think this has a huge number of implications for us in healthcare because this is what we look like just inherently with people coming and going, people covering for each other, et cetera. So we've got to overcome that, which means we have to be explicit about trying to promote positive relationships on the team. And we have to be explicit about things like, who's our network? How are we making sense of what's happening? Because if we make those explicit, we can pay more attention to them, and we can improve them more effectively. But I think this is critically important. And we don't do enough of this in healthcare at all. Do we have time and space for conversation and reflection? Do we create the time in the day for us to talk about how we are doing working together, taking care of this group of patients? I would say from the medicine perspective, the answer is absolutely not. Absolutely not. But this is where, when I talked earlier about the affordances and what's in the system and the geography, this really influences this. So this is Mount Sinai in New York. And they have the neatest architectural layout because their units are set up as triangles. So the beds are on the outside, but there's this central space. So all the providers are kind of physically forced to come together to this, at least they're in the same space during parts of the day, which increases the likelihood that they're going to actually talk to each other. And this is University Hospital with our little sub-nursing stations, scattered throughout the floor. So one of the things that I think is really sort of unfortunate and that we've purposefully now tried to come up with strategies to overcome is the fact that there's not natural congregating spaces for physicians and nurses in University Hospital. I see it as a big problem. So we're trying to kind of artificially create those. All right. So we've talked about our wicked problems. We've talked about characteristics of complex systems. And then we've talked about them a little more in depth in healthcare settings. And I wanted to give you an example just to tie them all together to try and make this as concrete as possible. So I'm going to talk about this collaborative care initiative that we have going on at university. And where we're trying to really redesign our inpatient care. And here's our motivators. They're the same things that you all are dealing with. Right? There's changes to how we're paid. And a huge part of those changes includes the patient experience being very heavily weighted in something like value-based purchasing. Then we had our own set of internal motivations, so we're always trying to improve. And also for our learning environment. So every accrediting body or opinion body who has anything to say about medical education is talking about interprofessional education and having authentic interprofessional experiences as learners. So we were trying to put this all together and say, well, how can we try and make the need to do these things come together in an improvement initiative? And we had tried a number of things before, not very successfully. So we had tried geographic localization, the idea being there that if our teams are all taking care of patients in the same area, we would have the same care coordination staff, we'd be working with the same nurses. Again, just increasing that likelihood of interaction and communication. So we tried that 2.5 years ago at university. It just fell apart horribly. It did not work at all. In part because the hospital was so busy that we couldn't, we couldn't initially get over this, put the patient in any open bed, regardless of what team's taking care of them kind of mentality. Safety checklists, I don't know if you all use those. We tried using them, and it never really took off. It was sort of intermittent and haphazard, whether people were using them or not. We tried doing bedside rounds with nursing. Again, it's not that people weren't interested to do it. It just didn't really come together. And we've got the communication whiteboards at university, and at both university and VA, we've done various pushes to try and use the whiteboard. And again, it's not like anybody thought that was a bad idea. It's just never really took off as a practice. So we started doing this collaborative care implementation where we were explicitly trying to partner with patients and their families and the interprofessional team to better take care of patients. And just the idea here, these were kind of the contrasts that we put together for ourselves. For our sort of traditional way of caring for the patients, where you can see, for us, and you all have spent time on medicine services at some point, there's a lot of time where people are talking about the patient without the patient there. So we were trying to move away from that and have the patient and their families more involved in setting those goals of care. Again, really working with the interprofessional team, and fundamentally, a lot of what we were doing here with the safety checklist and the localization were really more process-based attempts to improve what we were doing, and we wanted to be explicit about doing something relationally based. So the first thing that we had to do was actually look at what are our processes. If we're trying to get everybody together, what does their workday look like? Having the time that meds are passed being the same time that the medicine team is rounding, if you want to have nurses at those rounds, that's just not going to work, right? So we explicitly looked at, all right, for all these times in the day, where is everybody? What are they doing, and how can we all adjust our work schedules so that we are together more and together at the bedside? So this took, some time and some negotiation, because it really was changing where people were at different times of the day. We explicitly started reflection sessions in the afternoon. So for half an hour, and I'll say it never actually goes the whole half an hour, but at 1:30 every day in the team room for the collaborative care team, everybody gets together, physical therapy, nursing, care coordination, the physicians and the students, and talk about, all right, how are we doing? Now, sometimes, of course, they'll just talk about what's going on with the patients, and that's fine. But at least some of the time, they're talking about how are we doing? How did rounds go today? Do we want to try anything different tomorrow? And then we also have, sort of weekly meetings and then monthly meetings with our patient family advisory council. So there's sort of multiple levels of conversations that are occurring to allow us to make sense of how is this going? How are we working together? How do we need to improve? But you can see the evolution. These are all conversations that happened in those reflection sessions. And when it started, this is what we were hearing from the house staff. Like, oh my gosh, we're spending so long at the bedside. Like, I haven't even seen everybody yet today. And I'm not even focusing on what's going on there, because I'm just thinking of everything else I have to do while I'm listening to the nurse talk about what happened last night. So, we worked through that. And we started to get this sort of reflection of, all right, I can acknowledge that when everybody's together there at the bedside in the morning, I don't get as many calls from nursing later in the day, because everybody knows what the plan is, and they're not asking me, like, what's the plan? And they started to say they feel behind when they can't round with everyone. So like when social work or care coordination's not there, they feel like, oh, there's something missing from the plan. Like, I want them to be there. And then this is kind of where we are now. How do we include the family more often, which is logistically a challenge? And how do we orient new people to this model? So, as we implemented the model, one thing we did not anticipate sufficiently was how we orient, particularly the learners, to this model and get them comfortable in what's really a very different dynamic on rounds than what they're used to. And we thought about the affordances. So we are, again, take 2 on geographic localization, and it's actually working 90% of the time. Team member stability is critical. Now, we can't do it with our residents and our students, but we can do it with care coordination, physical therapy, and pharmacy, and with how we schedule ourselves. So all of those negotiations are things that we've done. Those whiteboards were like totally inadequate. So we moved to large Post-it notes. So if y'all are consulting on some of the medicine patients on 5ACU, you'll see these in the room. And so, again, good intentions with the whiteboards, but for what we needed them to be, they weren't sufficient. And I want to get back to the scale issue. So we've got some large scale things. We want everybody to experience interprofessional care. We want everybody to get the safety checklist, for example. But in terms of the actual care plan that's kind of co-created with each patient and family member and how that's communicated, that's fine scale. We can't standardize that, right? We can't say this is what we're going to do and have it work for everybody. So these are the kinds of things that we're we're negotiating. And here's just some observations for how it's going. Before, when we would kind of round as this huge group in the hallway that the patient can see, they can see that we're talking about them there in the hallway. And then we all go in. So in terms of the discussion of the patient and who's contributing, well, if it's just the medical team in the hallway, of course, they're talking most of the time, right? And when we actually go in and talk with the patient, and this is based on observations that are timed, so we can say, you know, how many seconds that patient was speaking. Patients and families were speaking 5% of the time, and pharmacy 2%, and nursing and care coordination was 0 because they weren't there. So when we have everybody together, now, you know, we're still talking the majority of the time, but nursing's talking, care coordination's there, and the patient and family are contributing. Almost 20% of the spoken time is a patient or family member speaking. And it's not just us telling them what you know, we think about their problems. It's more of a dialogue with them. And you know, this is an evolution. So we changed the schedule, then we changed it again, and all of those things. All right, so that was our collaborative care example. Just checking the clock. But so we've talked about all of these things. Hopefully the example I gave you was helpful, but what I want to leave you with are the next 2 slides. When we think about complexity science in healthcare, it reframes what we need to do. So we're moving from a process improvement approach to one of changing interdependencies. And those interdependencies include processes for sure, but they include relationships, they include the resources that are in the system. We're not just talking about individual skills. Is this a skilled physician? Is this a skilled nurse? What's really important to patient outcomes is how those people relate to each other. And we saw this in our observations. The teams with the best patient outcomes actually were teams that had struggling learners, struggling residents, people that were being seen by the clinical competency committee. But the team and how they related to each other was more than able to compensate for the skills of any individual. I recognize that there's going to be some differences with that from a surgical perspective. So we're not just thinking about defining roles and is everybody doing their job, but we're thinking about how do they do their jobs together? How do they adjust the hierarchy depending on the needs of the patient? It's not just planning and predicting. We've got to see what we're doing. We've got a trend. To me, we're looking at patterns more than we're looking at, you know, is this 1.12 today or 1.20. It's really what's the overall trajectory of how we're doing and how do we need to adapt based on the trends that we're seeing. And finally, moving away from these more structured communications, although not to say they have no role, they're very important. And I think when you're bringing new teams together, structured communications can actually be very important in terms of the relationship building. But we need to move to this. That has to be at least part of what we're doing. So we have our wicked problems, right? We've got these very difficult to influence healthcare systems where people are doing work in ways that make sense to them, right? And we've got to try and influence these systems. So complexity science forces us to look at the whole picture. We can't just look at this nursing unit. We can't just look at this clinic. We can't just look at radiology. We can't just look at anesthesia. We have to consider